Who's that from, Mike?
That's a blow-up of
Mike.
Carol and Sean.
Who's it from? Who's it from?
It's from Kevin and Okay, push the button again, guys.
That's from Carol and Sean. Candle ball. Your candle cheese ball actually is in there with my name on it. Hey, we'll play with that after. It's neat fly.
Let me try that.
These are
He's not too sure in the jaw.
Mom, show us your thing. Mom? Fran.
He's just helping you.
He's helping you.
He's helping you.
You gotta learn to share.
Brendan.
Brendan. Hey, Brendan.
At the front or back. Under, yeah, under.
Thank you.
That's also.
Brendan.
Yes, I saw those
Hey,
there
Brendan.
Yeah, I remember
Say
those.
cheese.
and never did. Oh, that's beautiful.
Be a
I
good
won't
boy.
be able to wear it with this, but I can wear it.
You want to, hey, Brendan, do you want to sit on the steps?
I got one of those books.
Oh, you have one about 5 times. You can come and see me? Come and see your slippers.
Honey, this is something I'll explain to you later, but it's, I got an acre in
Andrew.
Brazil.
Andrew, say hi to Carol.
Say hi to me.
You got Brendan's trees there?
No, this is protect 1 acre for wild.
Andrew, give Carol a kiss. Oh, so you know Brendan's trees.
In the rainforest.
I know, I gotta read about it.
Nice to get even.
Hey, Andrew.
Brendan. Brendan.
Where's Andrew?
How do you like your present?
You like the present?
That's right, you did say that.
Went to the craft show for everybody.
Well, let me see there.
Batteries? Oh, you're looking at the bottom drawer.
This is a recharge.
Gabe. Gabe, what are you up to?
I haven't looked in the mirror yet.
Hey, what's that?
Did you go all through this?
Hey, what's that?
Look at that. Thanks to Sean and Carol.
It's for earrings. You're welcome.
And say thank you to Carol.
You're welcome,
Brendan, here's a
Brendan, look at that.
look at Brendan. Here's a pair of gloves.
Wow.
And these are for Andrew.
What do you say?
What did you say to Grandma?
You're welcome. I hope they get you.
Great for
Earrings.
Look what I got, Brendan. Somebody gave me a nice deer. Isn't that pretty?
Okay.
Andrew, sir. Elegant dining tonight?
Anne asked if this was an apartment.
Yes.
She came in, you know, is this an apartment building? It's so big.
Say hello, Lee.
Hi.
Lauren, what do you have to say?
Hello.
How about you, Gabe?
Hello. 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 Hi. How do you do?
Merry Christmas.
Christmas.
Do you guys know any Christmas carols?
No.
Jingle bells.
Bells of lots of holly. La 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 la. Seasons will be jots of holly. La 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 la. Ring the bells and lots of holly. La 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 la. Here's the season to be jolly. La 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 la. Here, feeling la la. Jingle bells.
Yeah, that's good. Yeah, she's nice.
Take yourself a piece of pineapple.
Yeah, I'll get you this man. Nice house, Sean.
Watch it.
You're playing water. Close, Lee. Aaron, close the bathroom door. Aaron, close the bathroom door. Aaron.
Kevin, you're on candid camera.
You're right there.
Well, here I am again.
What'd you say?
Quite a microphone.
You have a headset on, you lose your hearing.
Hi, Molly.
Stop that. Those are all the bedroom doors.
Kids are already in there.
You know what else makes a big difference is the strings. She uses really good gut strings and stuff. I know they're really expensive, but it makes a big difference.
I saw Markov doing that.
Oh, he just flies though. I mean,
Well, that's what Markov did pretty well.
Yeah.
Did you see him when he, that's all he really did. Just taking each piece.
and then check out.
No,
This is Markov, the young Russian pilot. So he said he went to,
I haven't seen him before.
now that's the guy you probably heard about. He came with Orchestra 1 in last year. The other was spring, so in March. He was only about 23.
I saw Scott St. James. Hi. No, Scott St. John. That's who I saw.
Save the film for the house, okay?
Yeah.
Here we have the face of a broke lawyer who just bought a law practice. I can't believe I bought the whole thing.
I can't believe you're building a house without UDAP warranty. Come on into my office and for the low price of $1,000, I can show you how to get UDAP warranty. Start
They've
your
got
home
it with
today.
dust and stuff. And he had really good smell.
Yeah, he just stood there both He had a kind of dramatic, he had a handkerchief on his right and just throw the thing on about it.
He just wants an ice cream.
Oh, I know.
I agree. I love it. I am. I was last time.
I don't think you can focus. Oh, you got it going? Rob, we gotta turn the autofocus and the auto light on if you're gonna run it.
Laser, that's the only thing to be able to breathe really well and be able to play by ear.
Howdy, folks. Here we are at the O'Brien residence.
So, Sean,
I saw a special.
what's it like to build a new home?
Don't know yet. She ain't done. I'll tell you when she's all done. Before she broke.
And how do you get your wife to agree with everything?
Tie her up.
I think I heard about something.
Is that all?
Don't tell her. Dad, you didn't flash.
The famous Sean O'Brien here.
Cut.
Cut.
It's recording now.
Hey,
can't talk.
Don't go out to put a bag on her.
Just picked up the.
And look who's cooking.
Like a double bag of dairy.
Look at that cute little innocent face.
This is Cecil B. Rowlands.
Is he filming right now?
Yeah.
David, are you doing the time?
my eyes.
5 minutes and
I wish I could have started.
5 minutes and
Yeah.
Very fancy.
somebody made the dog severe. I've heard of the best. That's what you want to do. And it's got
Did you give Uncle I recognize that?
Get off of here, Grandpa.
no way for sure.
Look out, Grandpa, here comes another one. There's Andrew.
This is a payment for all those days you said, when are your kids gonna have to give you some grandkids? Those ones aren't even yours.
You're gonna hurt Grandpa. Grandpa's gonna hurt Mom. No, you got a picture?
What's going on here? What's going on with these little girls? I like those girls. Another voice is
Trying to see the camera. No.
Time out! Okay, let him go, let him go. Come over. Come over.
Gabe, indoor voice.
No. Okay, Lord, and there goes your Christmas present. No more wrestling this weekend. I got it.
That's right.
Hey, Dan.
Always need corn.
Harold, blow your whistle.
More important mitral regurgitation developing.
On that point, when you tell them about the possibility of endocarditis, when do you tell them they should receive prophylaxis?
I tell them that they should receive prophylaxis before any sort of dental work that's going to cause bleeding of the gums, extractions, root canal work, or extensive cleaning of the teeth, and before any sort of surgical procedure that may allow bacteria to get into the bloodstream, such as abdominal surgery or surgery of infected wounds or abscesses.
So it's not just urogenital surgery, it's any surgery that would deal with bacterial entry.
Yes, absolutely.
In those patients with mitral valve prolapse that have an arrhythmia, which ones do you treat and what do you use to treat them?
I treat based on the same criteria that I use in patients without mitral valve prolapse. That is, I treat individuals who either have symptoms that are troublesome or disabling, or in whom either symptoms or electrocardiographic findings suggest arrhythmias that pose a potential threat to life. Many individuals have occasional palpitations, whether or not they have mitral prolapse. I usually do not recommend treatment for those individuals, since reassurance about the benignity of their palpitations and the conditions seems to be of sufficient benefit. In individuals who are troubled by frequent ectopic beats or sustained paroxysmal tachycardias, beta blockers tend to be very helpful. People have to make their own decision, that is the patients, about whether control of the arrhythmias or the symptoms induced by beta blockers are more troublesome. The occasional patient with life-threatening ventricular arrhythmias requires intensive evaluation and individualized treatment, sometimes requiring use even of experimental antiarrhythmic drugs to achieve control.
My dilemma as a primary physician is wondering when to look diligently for mitral valve prolapse. And if I have a patient with an unexplained arrhythmia, but in whom I do not hear a click or a murmur, is it worthwhile, and should I get an echo in order to look for mitral valve prolapse, or is it not worth it?
In that setting, you'll find a somewhat higher than population average prevalence of mitral valve prolapse. We looked at a large series of individuals referred to our echocardiography laboratory, and perhaps 10% of individuals with unexplained palpitations turned out to have mitral prolapse, twice the prevalence in the laboratory. I'm not sure that that is necessary unless it's important to the patient to have a label, because I think the treatment of palpitations and arrhythmias doesn't differ.
Vince, you had a question.
Yes, just like arrhythmias, excuse me, neurologists are very often asking us, should we obtain an echocardiogram in patients who've had cerebral symptoms, for example, young women? Again, do you get what do you tell them? Do you obtain an echocardiogram or not?
In young women, I think it is probably worthwhile doing. The evidence in the literature, which seems sensible to me, is that in young women, a higher than expected proportion who've had cerebral ischemic events will be shown to have mitral valve prolapse, 40% in the original studies by Barnett. In older individuals, after the age of 40 even, that seems to disappear as other causes of neurologic events become frequent. Turning this around, the risk of cerebral ischemic events due to mitral valve prolapse is terribly low among the tremendous population of people with mitral valve prolapse.
Would you regard oral contraceptives as being contraindicated or relatively contraindicated in women with prolapse?
I'm not sure. I worry a little bit more because of this evidence about cerebral ischemic events. But interestingly, none of the studies to date relating mitral prolapse to cerebral ischemia have implicated a cross effect of oral contraceptives. So I would worry more. It's not an established contraindication.
But do you put those patients on an antiplatelet drug? Do you put the men on aspirin? And what do you put the women on if you do use something?
After they've had a cerebral ischemic event, the practice recommended by the neurologists at Cornell has been to use full-fledged anticoagulation with Coumadin for a period of 6 to 12 months, followed by antiplatelet agents, usually a combination of low-dose aspirin plus Persantin.
This is someone with just a TIA and mitral valve prolapse?
If there is if the neurologic findings were clear enough to make the diagnosis a well-founded one, what we see at least as commonly are people who've had odd symptoms that might be a TIA but can't be put together as representing a distinct cerebral anatomic event. And in them, certainly I wouldn't recommend, I'm sure our neurologist wouldn't recommend full-fledged anticoagulation.
I'd be a little hesitant,
yes,
too. I'd like to try the aspirin
right.
first if it's going to work.
I'm sure different centers have different recommendations.
I'd like to go back to something you discussed earlier in your concept of mitral valve prolapse. Sure. Basically, you regard prolapse as a disorder of connective tissue. My question is this: if it's a disorder of connective tissue, which occurs not only in the mitral valve, but obviously connective tissue is all over the body, why is it that the mitral valve is the focus of all of our discussion?
One theory about that, which certainly hasn't been proven, is that the mitral valve bears the greatest load, since when it's in its closed position in systole, it has to support the systemic arterial blood pressure. The other valves, aortic, pulmonic, and tricuspid, all bear somewhat lower to markedly lower blood pressures when they're in their closed position. Therefore, it may be that the mitral valve faces the greatest workload, which it can't tolerate.
You saw our patient at the beginning of the program. She's had documented mitral valve prolapse, both with the auscultatory changes and echocardiographic features, which showed a mild degree of prolapse. Mm-hmm. What would you tell this lady? She's just been diagnosed. What do you tell her? I
would tell her first that she has mitral valve prolapse, explain that it is a very common condition affecting 5% or more of the population, that it is so common and so benign that it is often hard to muster up the courage to call it a medical condition rather than a variant of normal. I would explain that there does appear to be a small increase in the risk of endocarditis, so that antibiotic prophylaxis should be taken, and that it does appear to be associated with palpitations, so that it provides an explanation for her palpitations. I wouldn't make much of other possible, much more unlikely complications, and I would treat her as she has been with beta blockers to control palpitations, making clear that that treatment should be used based on a balance between the control of her symptoms and whatever annoyance taking pills is to her or any side effects she might experience.
Now let's take a moment to summarize our discussion of mitral valve prolapse. Mitral valve prolapse is the most common cardiac valve abnormality in the United States, affecting up to 5% of the population. Mitral prolapse most often is inherited as an autosomal dominant disorder of connective tissue. Although many symptoms can occur, the most important to the diagnosis is palpitations. The diagnosis of mitral valve prolapse is made either by auscultation or by echocardiography. Thoracic bony abnormalities are common. Complications include infective endocarditis, systemic embolization, and mitral regurgitation. Sudden death, while reported in isolated cases, is so rare that its exact relationship to prolapse is in doubt. Although infective endocarditis is very uncommon, prophylactic antibiotic therapy is indicated when bacteremia may occur, such as dental procedures. Finally, the symptomatic patient should first be reassured of the benign nature of the condition. If simple measures, such as avoiding caffeine, do not control the palpitations, then treatment is the same as for arrhythmias due to any other cause. Beta blockers are particularly effective in many cases. This concludes our discussion of mitral valve prolapse on Cardiology Today. We hope that we have provided you with some insight that will help you in caring for your patients with this very common problem. Until our next program, thank you for joining us.
I was at my most stressful time when my husband was traveling a lot and my children were small and I was with them a lot, and I have found that probably stress leads to this, but at that particular time I can remember having pains in my chest and in my arm and funny little pains into my jaw, and I would say that had to be 15 to 20 years ago.
And
it was never diagnosed. I would go to a doctor and they would say, oh, well, all the tests are fine, there's nothing wrong with you. And at times I thought, well, maybe I should go see a psychiatrist or something. And that's the nicest thing about this whole deal. Knowing that I did have something wrong with me, I feel like, now I can deal with it. Fear is the worst thing. And if you know what's causing these palpitations, then if you're an intelligent person, you can deal with it, and you know you're not going to die, and you're not going to have a heart attack, and you're not going to pass out. So I think that knowledge is very helpful. If you know what you've got, you can deal with it.